There we go. All right. Well, welcome, massive audience, to uh this month's installment of outdoor safety and first aid topics. Instead of a one topic for the whole presentation, I thought we'd do a little bit of potpourri, a little dash of four different things. So today we're going to be talking about some eye injuries, burns, blisters, and nosebleeds. I always have to put the disclaimers out there that this is informational only. I may talk about some medical treatments or fitness, diet, nutrition, and it's for personal use only. You should consult with your medical provider if you are starting a new exercise routine, such as getting out and hiking or backpacking. And if I mention any specific items or companies, I don't have any financial ties to them. I am just merely using them as an example. For those of you who don't know who I am, I'm Dave Dickinson. I'm a PA. I've been one for 17 years. I have a strong interest in wilderness medicine and actually have my fellowship in it. I'm an avid hiker and I volunteer for for a couple organizations around here, including the White Mountain National Forest and the Pimby Valley Search and Rescue. And so, all right, so we're going to be talking about these four topics. We'll go over some blisters, thermal burns, so that does not include sunburns. That'll be a different topic for another day. Nosebleeds, and finally, eye injuries. Just as a warning, due to the nature of some of these injuries, there are some images in here that might be disturbing to people. So I'll do my best to warn you beforehand, but just be forewarned. So, blisters, very common. All right. There's probably very few people on this earth who have not had a blister at some point from various reasons. Um, there have been some surveys out there that have shown like ultra marathoners, 26 to 76% of them have gotten them, AT hikers, 64%. So this is a very, very common injury to happen while we are out hiking, while we're out backpacking. And blisters themselves come from friction. All right. It's an object, and in this case, it's usually a sock or a shoe that starts rubbing up against your skin here. And you start getting a separation in this area right here, the stratum spinosum. And as it rubs, becomes inflamed, and eventually these areas start splitting and start filling with fluid, and that's where we get our blisters. So some of the risk factors, the biggest risk factor for increasing friction is actually moisture, whether that's moisture coming from outside, rainy, hiking, walking through a stream, walking through a puddle, or if you're just got sweaty feet, like I do. I sweat a lot in my feet. So on hot days, the sweat's going to soak into your sock. That's going to increase the friction and can increase your risk of blisters. Also, the distance. Obviously, if you're walking for a long period of time, the more even if it's a small amount of friction, time will eventually start causing those layers of skin to split. And finally, new footwear. This is actually a big one. A lot of people get into trouble with new footwear because new footwear, new boots, new shoes are stiff. They haven't been broken in yet. There's places that can actually start rubbing on your feet that will increase your risk of blisters. I actually got some new boots a few days ago, and I am currently breaking them in. And we'll talk about some ways that you can do that. So, again, most people have dealt with blisters before, but they start off small. They start off innocuous. They start off as something called a hot spot. It's these little red, very painful, irritated areas on the areas that are rubbing. Classically, back of the heel here. Sometimes you'll see them on the toes. And people may actually not feel these at first, or it might just be like a little bothersome and they don't really think about it. But as that friction continues, those layers of skin start to split. There becomes a little void in there, and nature hates a vacuum, so it starts filling up with fluid. And we start getting a blister. This is a great picture of a nice blister that has a little bit of hot spot around it. All right. And sometimes they can get really, really bad. And when somebody ignores it too much, they become very big and they start peeling away. exposing the deeper layers of tissue. This is actually a friend of mine who admitted to ignoring her hot spots and her blisters while she was hiking the Sierra Nevadas, which is very dusty. Dust got in there, and she got back home to New Jersey and was laid up for like a week, getting better. So let this be a lesson to not ignore things. So what do we do? So once we start feeling that we're getting a hot spot, that's when we're supposed to jump on this. That's our body saying, hey, I'm going to develop a blister if you don't do something about this. All right. So padding is the first thing. So classically, moleskin is this felt-like material. It's got sticky pads on the back. I don't really want to pull any of these off, but they kind of look like this. They either have a circle in the middle, which this is more for like smaller blisters. Um, and what this does is it raises the area around it. So whatever's rubbing on rubs on this instead of the skin underneath. But they do have solid pads here. This is probably better uh, for your hot spots. You can also use other things like a band-aid works just fine. It may not stick very well, but it does the job. Medical tape that's in first aid kits, athletic tape, all of this stuff is any barrier that you can do will help prevent a hot spot turning into a blister. Now, there's always a question about, people love to pop things. Pimple popper's on there. She's popping a lot of stuff. The question is, do we want to pop blisters? Because sometimes they're big and painful. Ideally, you shouldn't drain or pop blisters while you're outside, just because it's very hard to keep it clean. If it's large, something like this, it's probably large, probably painful, it's probably going to pop on its own. Get it as clean as you possibly can. Clean your knife or needle or whatever you got. Make a little poke in it and drain it and then bandage it. All right. What I do in the urgent care with this kind of stuff, if I saw something this big, I'd sterilize it, I'd drain it, and I actually cut the skin off so it doesn't slough off, it doesn't rub anymore. So, but only if you absolutely have to should you drain a blister if you're outside. In terms of determining whether or not you should abort a trip, whether it's a multi-day trip or just a day trip, kind of depends on how well you or the affected person can move, how much pain you're in, if there's an infection, if you're on a multi-day backpacking trip and it's starting to look infected. So really kind of use your common sense. If you're having a hard time walking because it's so painful, or if it's starting to look infected, get out. It's only going to get worse. Finally, blister prevention. So breaking in of new shoes and boots. So there's many stories, especially because I follow the Appalachian Trail hiker community. Like people will buy new boots and just like go walk for like 10 or 15 miles. It's the worst thing you can do. People will always get blisters. So best thing to do is if you get a new set of footwear, wear it to work, wear it grocery shopping, wear it to your presentation at the library. Just anything that's not very like super impactful to just break those boots in. You will definitely be helping your future self out with that. We talked about padding those hot spots as soon as you get them to help prevent any development of blisters. Reduction of friction. There are some lubricants out there like Body Glide that you can do. An extra pair of socks. Socks can actually help reduce friction. If you put one sock on inside out and then the sock right side on over that, gives you another layer of protection. And then reduction in moisture, changing your socks. If they get wet, wringing them out, airing your feet out, or even drying powders like Gold Bond. They don't make talcum powder anymore, but like cornstarch can help reduce friction. All right. Any questions on blisters before we head on to thermal burns? No. All righty. Just stop me at any point if you have any questions.
The two sock thing works because they had us do that in basic training with our combat boots.
Yeah, it's so simple and it does work. You do have to remember that your two pairs of socks takes up more room. So if you have like a pretty tight fitting boot, they actually make sock liners, which are really nice. They're thin. Usually they're like polyester or silk, and they are very, very thin. But they're another great thing too that you can get. All right. So thermal burns. Again, we're not talking about sunburns. We're talking about like other things that burn you. Classically, people think about campfires. This is actually unfortunately a common occurrence in the summer for us in this area. For like ER visits and stuff, people will sometimes fall in the campfires. Usually it's the teens and 20-year-old guys who are drunk, but unfortunately little kids will get curious and stumble in as well. When we're out backpacking, obviously we have sorry, not obviously, some people will have stoves and the heat is there, but the boiling water is actually the worst thing. A lot of the dehydrated meals need boiling water, and boiling water is a very, very high temperature, very apt to burn people if not handled correctly. This is supposed to highlight the metal. So, obviously in the hot areas of this country of the world, metal just soaks up heat. It is, just living here over the past 10 years, it's getting a little hotter every year here. So that's going to be a problem. So, if you a gate or a car or anything like that, you can definitely burn yourself on some hot metal. We don't have to worry about thermal springs here, but out in Yellowstone or in Iceland, they got thermal springs that can get up to 150, 60, even up to boiling temps. So I think every so often there's somebody who falls into the thermal pools out in Yellowstone because they're being dumb, um, or by accident. Maybe it's not their own fault, but usually it's because they're trying to get too close. So that's something we got to worry about. And then lightning. Lightning can cause burns. That's its own separate talk altogether. But lightning obviously can cause a lot of issues, including burns. All right. So I remember when I was in Boy Scouts, we learned about the three different degrees of burns: first, second, third. In the medical community, we use superficial, partial thickness, and full thickness, but it still means the same thing. All right. So again, a lot of people have had burns in their life. This is a pretty classic first degree burn. This probably is somebody who reached into like an oven and burned themselves on the rack, but still, it's red, painful, gets better in a few days, doesn't blister. Not too much to worry about in terms of first degree burns. All right. Second degree, we're getting a little bit worse. So these are painful as well. There's usually some associated first degree burn around it. So this is a great example of this. First degree here, little second degree there with the blistering. As soon as it blisters, it's automatically a second degree burn. And again, these are painful. And as you can see in these, you can see how deep it starts going. So the dermis, when we were talking about blisters before, this is right where the blister formation happens here. So we're getting a little bit deeper. And then third degree burn, these are bad. They're red. They can be also associated with varying degrees of first and second degree, depending on what you're dealing with. These are usually boiling water is not going to cause this. This is oil. This is falling into a fire, electrical burns, things like that. There might be some bleeding because, again, we're getting down into these deeper tissues where the blood vessels are. But the thing about these is these don't hurt. These are numb. These are insensate. Because as we're getting down here, this is where the nerve endings are. So I get really worried if someone comes in with a burn and said, this doesn't hurt. That tells me we're really deep, and that's a problem. The other thing about burns, not only their appearance, but how much of a body is burned. So there's a couple ways to calculate that. First, we have a rule of nines. This is a way to like divide the body up into different areas to kind of roughly estimate how much of a body's burned. Now, this is more for the medical community, but it's still good to know in terms of like when we get into reasons to evacuate, it's good to know how much we're dealing with. So head is not, so these half percents, this is all for like front of the body, but if you think front back, 9%, 9%, 9%, 9%, 18, 18, 18, 18, and then genitals are 1. Babies are a little different because their heads are disproportionately bigger, so babies have a little bit more on their heads. The easy way is the palm method, 1%. So if you roughly can do, if someone has a burn that goes up to here, you go 1, 2, 3. All right, it's about 4%. All right, and that gives you kind of a rough estimate. All right. So for all the different burns that were treatments, the first thing we got to do is we have to remove the source of the burn. You know, this guy, he's got some charring on his clothes. That's probably still burning him. We need to get that off. We need to get the oil off, the water off. We need to get them out of the fire. You know, this is pretty common sense stuff. And then we run it underwater or submerge it in cold water, 20 to 30 minutes. Right. We need to get that temperature down to cold to stop any further damage. Don't use ice. You know, don't put an ice pack on it. That's too direct. This needs to be water, non-ice water. All right. So first degree burns. Again, we've all pretty much had first degree burns. Very low risk of infection. This one's actually not a great picture because there is a little blistering right there, but these don't go down very deep. They're just painful. So using some pain medicine will be just fine. They do make some burn relief ointments. This one's good because it actually has some antibiotic in it. But they don't point it out exactly here, but there are some that have like a Novocaine like medication in them to help with burns. So that's actually pretty helpful. But again, lasts for a few days. I do tell people you do have to be vigilant for blistering because the blisters may not form immediately or even until the next day. All right. All right. Second degree burns. So these now we're getting a little bit deeper. And what I want you to think about when we're talking about blisters and burns is that the blister that forms the top of it, those are like 2 or 3 layers of skin. So as soon as those blisters pop, those layers underneath are now exposed. And our body, you know, the skin is a really great physical barrier. So if you have an opening, the bacteria that normally lives on your skin out here is just going to start migrating in and cause infection. So how we approach burns like that are deeper, partial thickness and full thickness, is we actually have to build back that layer of skin or those layers of skin. So first things first, we're going to clean this. We're going to remove dirt, debris as best we can, being very gentle. We're going to use some soap and water or antiseptic wipes. Usually there's antiseptic wipes in first aid kits. This is a blister medic pack, but they have antiseptic wipes that you can use just to wipe things down. Then we're going to put on some antibiotic ointment. That's going to be our first layer of skin. And if you don't have antibiotic ointment, if all you have is Vaseline, that's fine. And then we're going to bandage it. Again, that's another layer of skin that we're building back. We're protecting our deeper structures of the body while we get body in it. Again, these are very painful. So definitely some ibuprofen, some Tylenol, or similar medications will be very helpful in reducing pain and helping the affected person become more comfortable. Just like foot blisters, do we drain these again? If they're big, they look like they're going to pop on their own. If it's going to hinder somebody's ability to get out, you can try to drain these. All right, but don't be too aggressive with it. Just drain it, bandage it, get out. Again, let us in the front country take care of these to try to keep them as clean as possible. Clean them out. All right. Finally, we have third degree burns. Sorry about the picture. Didn't warn you about the picture. So again, these are very deep burns. These are getting down into the bones, the nerves, the muscles. So I think it was a girl in Africa somewhere. And so very similar to the second degree treatment, we're going to clean these very, very gently. Again, they can't really feel this, but we're also going to be watching out for first and second degree burns to treat those as well. We're going to put some bacitracin and we are going to bandage the heck out of this. Pain control, again, for the areas that are painful. And one of the other things our skin does is it keeps us from evaporating moisture. You know, we evaporate moisture from a bunch of different reasons, but if we didn't have skin, well, we'd lose it a lot quicker. And so with all this exposed, your body's going to be reacting. It's actually going to be sending white blood cells and inflammatory mediators to the area. So you're going to be losing fluid. So for larger areas of burns, especially third degree, like 10 or 20%, if they can drink, you need to start giving them fluids. Actually, in burn centers, like down in Boston, they actually have procedures for like when people have burns, how much fluid they get every hour, every 24 hours to keep up with fluid loss because they know that's actually a pretty big reason people die is dehydration. All right, so kind of a lot of reasons to get out, but if somebody has an inhalation injury, so if they actually like this is more for like if you're in a forest fire or in a firefighters, we have to worry about this or people in burning buildings. But again, forest fires, if you inhale hot air and it burns your lungs, if you have burning around the mouth or the nose, big problem. You need to get out. Burns to the chest, because if as you burn, skin starts to tighten, that can restrict your ability to breathe. Hands, feet, genitals, mucous membranes, or face. Those are all the really worrisome areas for burns. Not only because of mortality with like face or mucous membranes, but hands and feet for the ability to walk, the ability to uh, use your hands effectively, and genitals for reproduction. Circumferential burns, so all the way around. Circumferential burns also increase risk of scarring, especially if they're over joints. Scar tissue can reduce the amount of movement over joints, so we need to get these people out as soon as possible. Third degree burns more than 5%. That's a pretty low number for, I'd probably get any percentage out, honestly. And then second degree of greater than 10 to 20. Infection burns, control pain, and then lightning injuries. Obviously, they have a lot of other problems besides their burns. All right. I put the dog picture just so we, after seeing horrific burn pictures, we could look at a cute dog. All right. Nosebleeds. I don't like nosebleeds. So this time of year, it's very dry. It's very common for nosebleeds to just spontaneously happen. It happens. Trauma, obviously, somebody falls, knocks their face on the ground, or if you're a nose picker, you can get a nosebleed. Actually, being sick with either allergies or a viral infection, if you're having a lot of nasal congestion, causes blood vessels to dilate, makes it bleed easier. Obviously, you're going to bleed a little bit easier if you're on a medication that makes you bleed, like aspirin or Coumadin. If you have something like hemophilia, like the SARS kids in Russia, high blood pressure, alcohol use, and actually nasal steroids. If you use something like Nasacort or Flonase, that actually weakens the blood vessel walls too. So we bleed from a couple different places. So the vast majority of people, like when we get nosebleeds, are coming from what's called an anterior bleed. So this picture is actually looking at the wall of your septum here. We call this Kesselbeck's plexus. It's these little areas right here. This is where the majority of people are going to bleed from. And then if you look on the outer wall of uh, your nasal passages, we have these blood vessels back here called Woodruff's plexus. These are, as you can see, these are bigger arteries than the little ones out here. So these, when you get a bleed back here, are much more severe, much more prolific, and potentially life-threatening. All right. So we get one of those nosebleeds from the front. Again, because it's so far forward, see, this yellow, this is the divide. It goes all the way back to our hard palate here. Usually it's only going to be coming from one nostril. It could just be a little trickle, or actually can be bleeding quite profusely, depending on what the cause is, what your risk factors are. Posterior, people sometimes can bleed from both nostrils because it's actually like sneaking around the back of the septum there. But another problem is it actually can start going down the throat. You're looking back at the throat and there's this clots just blood going down, and they can vomit, or it can even go down to your lungs or cause airway compromise. So again, these are really problematic. So treatment of nosebleeds. So when you type in nosebleed treatment, this is like one of the more common images. Does anyone know why this is a problem? Why this image is a problem?
Forcing it back down your throat.
Yeah, yeah. So you're leaning back, and that's you don't want to do that. You don't want blood going down the back of the throat. Also, he's holding his nose too high. So what you want to do is you want to lean forward and you want to put your fingers. So when you bring your fingers to the tip of your nose and go back, you'll feel the bony portion of your nose right here. You want to be just in front of that and squeeze really, really hard for like 15, 20 minutes to get that to stop bleeding. The harder you can squeeze and the longer you can hold it, the better. Right. You can try to put a packing in there. You know, some people with like mild nosebleeds in the winter, they'll get a piece of tissue and wad it up there. You can certainly try that. Just make sure you leave something out to hold on to so you can pull it out. Don't shove like a cotton ball up there and expect to try to get it out. Afrin, this is oxymetolazine. This is a nasal spray some people will use for allergies, for nasal congestion. If you have it, that actually can be very helpful to help stop some minor nosebleeds. Um, Posterior nosebleeds, again, these are very, very prolific. Uh, Basically, all you're doing is leaning forward and getting out. There's really nothing you can do in the backcountry for a posterior nosebleed. They have like special balloons and stuff they stick back there and packing, and it's a whole thing. They have to get seen by ear, nose, and throat doctor. It's a procedure. So, all right. When are we going to get out? Obviously, if you think you have a posterior nosebleed, um, nosebleeds that aren't stopping after 45 minutes to an hour of like good long pressure. Um, if you're having blood loss symptoms, shock symptoms like dizziness, shortness of breath, sweating, rapid heart rate, that obviously means something bad is happening. You need to get the heck out. Facial injuries, you know, if the nosebleed is because someone fell and smashed their face on a rock and their nose is off kilter and they're missing teeth, nosebleed is the least of their worries, but you need to get them out. And then, yeah, if they have blood thinners or any bleeding issues, you need to get them out as well because you don't know if it's going to stop in a reasonable amount of time where they can actually start getting into blood loss issues. All right. Finally, eye injuries. Here's the warning for I'll tell you about the pictures when they come up. All right. So just a little bit of eye anatomy. So the white part we call the sclera, and then there's a covering over the eye called the conjunctiva. That's the thing that gets irritated and red when we get pink eye. We have a cornea, which is the clear covering of the eye that lets the light in. The iris is the colored part, and then the pupil. Then we have the lens back here. Right back here, we have a retina where the light comes in and creates the image like the film in a camera. So a lot of stuff out there that can hurt our eyes. You know, lots of sticks, a lot of branches, a lot of roots. They're just waiting to poke us in the eye. Not so much around here, but obviously desert and dry areas of the world, dust storms, sandstorms. But certainly on a windy day on a dry dirt road or a dry parking lot, you can get some stuff in your eye. There's self-injury. Somebody, you know, if someone's like, you know, itching their eye and they poke themselves, or if they're doing that in their sleep. And then we're finishing up with ice fishing season, and then we're going to be getting into liquid water fishing season soon. So fish hooks, sharp pointy things out there. So we're going to go over some of the more common eye injuries. So this is a subconjunctival hemorrhage. So be underneath the conjunctiva, subconjunctival, and on top of that white part, the sclera, there's a lot of blood vessels. You can actually see them right here in the eye. And sometimes it's spontaneous, sometimes it's from trauma, sometimes it's high blood pressure. One of those blood vessels just pops. And usually it's not a huge deal. Some people get this after vomiting or sneezing too hard. Usually people don't feel it. It's more often than not somebody else tells somebody they have it because they notice that there's a big red spot on their eye and they look in the mirror and go, oh my God, my eye's going to fall out. It's not the case. Sometimes they feel like maybe like it feels a little gritty, but that's really the worst I've ever seen. No effect on vision. because it doesn't actually go into the pupil. But sometimes if you are on blood thinners or the trauma is bad enough, you can actually start getting blood around the whole eye. And it's not so much that the pressure pushes here, it actually starts putting pressure on the back of the eye. So if you start seeing someone's got like half or more of their eye like this, they need to get seen. But typically, if it looks like that, not a problem. That's essentially, this is like a bruise. It's just going to change some funky colors and it'll go away. Then we get into some of the more painful things. So corneal abrasion. So an abrasion, just like a rug burn or a scrape on the skin, this is a scrape on the cornea. Typically is from trauma. These are not spontaneous. And they are very painful. People will come in with their eyes closed. They won't really want to open their eye because it hurts so much. Their eye is red. It's irritated. They're tearing because the eyes really know only one thing to do is to wash things out. So it makes a lot of tears. And with this, you can see the white part right here. This is a pretty good size abrasion. They're not always this obvious. Um, but the problem is, depending on what caused the injury, you can't really tell just looking at it how deep this is. Was this just on the surface or was it deep? All these people should be evacuated. And the reason is when we're in the clinic, I have some dye non-toxic dye I put in the eye, and then I shine a black light on it. And this dye settles into any depressions. And so this is what a corneal abrasion would look like. The problem is if it goes deeper, the abrasion's up here, but I see that dye is being washed down, not from tears. Tears come from here or here. This is coming from a particular place. This tells me that that forward part of the eye, it actually is got intruded into. So there's eye goo leaking out. So that's why anybody who has any like eye pain, like a corneal abrasion, needs to be evaluated because we got to find out if they're having the inside of their eye leaking out to the outside of their eye. For pain, you can give them Tylenol and ibuprofen, and we'll talk about some eye patches in a couple slides here. A close kissing cousin is a corneal foreign body. Very similar presentation to corneal abrasions. It's going to be red. It's going to be painful. Sometimes, depending on what it is, you might see the object. In the wilderness, you're probably going to see wood. If I had to guess, this is probably a piece of metal because there's a little bit of rust around it. Metal tends to rust in the eye, but it could be a piece of dust. But yeah, wood. I haven't seen wood yet, but I know it's coming at some point. Similar to the corneal abrasion, we need to know if that got any deeper into the anterior chamber. So all these people need to be taken out. You can try to irrigate these things, but unfortunately, if the tears aren't doing it, you blasting water probably isn't going to do it. These things are usually stuck in there pretty well. We have these it's literally a little Dremel, like a tiny, we call it a burr drill. That would have to go to the operating room, but this thing, it's just a little tiny Dremel, and we numb up the eye and we go, and it just flicks it right out. So for the corneal foreign body, corneal abrasion, we should talk about patching these. It's going to make them feel better. It's going to keep that eye closed. You could simply just take a piece of tape and just tape right over the eye. It's probably going to be better if you get some gauze out, kind of ball it up, make it nice and soft, and then patch the eye. You can leave the other eye open. We'll talk about a different eye injury in just a moment, why you would cover up both. But for corneal abrasions, corneal foreign bodies, we should patch them out. You can get really fancy. This is from a Boy Scout manual. A patch with 2 handkerchiefs because every Boy Scout has a handkerchief, so you can just kind of make one up. But honestly, a tape over the eye, it's going to be fine, just fine. All right. Warning, nasty pictures. All right. So penetrating injuries. That's a fish hook in somebody's eye. And this person had a puncture, but whatever was in got pulled out. And you can see because it disrupted the iris here, and that's part of the iris coming out here. So if someone comes to you in pain and they got something like this, that means they did get poked in the eye and it came out. All right. So what you're going to do is don't take the object out if it's still in there. Certainly not if it's a fish hook, but if it's a twig or a thorn or something, leave it in. We're going to patch that eye and we're going to get them the hell out of there. All right. Because they need antibiotics, they need eye surgery potentially. These people are not like, this is an eye threatening issue. All right. So we talked about covering one eye for the corneal stuff. For these, we want to bandage. So we're going to take a sock, a bandana, toilet paper, whatever you have. And if they have something still sticking around their eye, we need to immobilize that because the more it moves, the more injury it could potentially have to the underlying eye structure. So you could use a cup if you have access to one. This is actually, you just poke a hole if it's something really long and you tape the crap out of this. And at the same time, we're covering both eyes. It's because the eyes move together. So if your left eye is open and you're looking around, you're moving around that stick or fish hook or whatever. So you are going to blindfold these people. And it's going to be a big trust exercise about getting them out. You might actually want to just call to get people to carry these people out to help reduce any further injury. But yeah, that's worst case scenario for eyes. All right. And that's the end of the presentation. Any questions on anything I talked about?
Maybe I don't want to take fly fishing lessons with
Yeah.
Dawn.
Well, the thing about fly fishing, a lot of times they have barbless hooks, so
Oh.
you can actually just back those suckers out, but you still need to get seen if you hook yourself in the eye.
Keep my distance.
Yeah. You have glasses.
Yeah.
Should be, that's better.
Yeah.
So with the third degree burns,
Yeah.
you said typically you don't feel it. Would you feel it around it?
Yeah.
Or is it because the whole thing is numb?
Yeah, so the area is insensate. But again, because depending on the cause, if you had hot oil that splashed on you, the last third degree, I haven't seen a lot, but the last third degree burn I had was a cook who somebody, I think he dropped the food in and oil splashed onto his hand. So it was just right here. But he didn't have any sensation here, but where the oil spread down, he had pain on his wrist. So that's again, it's usually not a pure like second degree, first degree, third. Sunburns will usually be wholly first or second degree just because of the area is exposed enough. But yeah, usually like third degree, there's going to be a mix unless it was like a car fire, a house like their entire body was exposed to flame, and it's just such a large area that it's almost like trivial to be like, oh, he's got 90% third degree, but he's got 5%, 5% second degree. Like you don't care at that point. But yeah, you're probably dealing with more than 1 degree of burn if you're dealing with second or third degree. And there was at some point they talked about like fourth went down to the muscle, fifth went down to the bone. They just got rid of all that, and now it's just deep.
Yeah,
like anything that's deeper than that, just it doesn't. That point doesn't matter. Yeah. All right. Sure. Thank you.
I had 2 nosebleeds in the last 2 weeks.
Yeah, they're so bad. Drink lots of water and